Well, hello and welcome to this Kent webinar. I'm very excited to be again talking about this amazing technology. And I'm even more excited about sharing the podium with one of my esteemed colleagues and friends, Dr. Thomas Serena. Tom, good to see you.
Good to see you, Jeff, as always.
Thanks so much for joining us.
My pleasure.
So, Tom, I understand that you've been using this technology for a while.
We have. We've been using it now for several years, and we have a number of grants that have allowed us to study it. And we'll talk later about how we've compared it to transcutaneous oxygen measurement.
Excellent. I'm excited to hear that. You did a great publication recently, and that was outstanding. You're going to review that for us as well?
We'll take a look at that. That was really our first go at how much is this like TCOMs? I mean, how can you compare NIRS to TCOM? And it turns out, as we're going to show you later, it correlates pretty well. And I think you have some slides that show the same thing.
Yes. So we were asked really to talk about interpretation here, Tom. We've done prior lectures and webinars talking about what this technology is, and we're going to give you a brief overview. But what I'd like to do is spend the vast majority of my time and our time talking about interpretation. What do these pretty pictures mean?
Yes, and that's the challenge with any technology, any imaging technology, from TCOM to a lot of the newer technologies. You need to, it's just like the radiologist, you need to learn how to interpret them.
Absolutely. So without further ado, we'll get into the lecture. We are going to be providing the audience and the members here that are viewing this with an opportunity for Q&A at the end. So we're getting about 30, 40 minutes of lecture, and then we'll invite you to join us for the live Q&A. So without further ado, let's get into it. So near-infrared technology. Technology is based on analysis of light, specifically the near-infrared spectrum of light, typically found between 600 and 1,000 nanometers of light. This is the area that we're focused on. This technology, Tom, as you're aware, has been around for a long time. It's been around since the 70s. And it's had a wide variety of applications, largely started off in the industrial applications, more recently translated to the medical field. And I think that has been largely due to the fact that if you remember these cameras, when we first started using these cameras, they were big things on crane type devices. And now they've actually decreased the size, made them much more readily available in the clinical. And they're handheld devices now. So we're going to talk about that. It's important to realize that this is not hyperspectral. Many of you have heard about hyperspectral imaging. Hyperspectral is the entire gamut of the light frequencies. And this is a very select, as we talked about, in between that 600 and 1,000 nanometers. And if you look here at this slide, you can see the hyperspectral light range on the top from ultraviolet all the way out to near infrared. Again, 300 to 2,500 nanometers, that is hyperspectral, taking the entire wavelength. Again, this is a very narrow focused area of wavelength in the infrared spectrum of that broad band of light. And we are looking at imaging and detecting the unbound hemoglobin and the oxygenated hemoglobin. Unbound hemoglobin, right around that 750 nanometer range, oxygenated hemoglobin at about 850. So those are the frequencies of light that we're looking at.
You know, one of the really neat things there, Jeff, too, is that because they use 6 different wavelengths when they're looking, interrogating the wound, and some of those are in the visual spectrum, you also get a nice picture of the wound as well.
Absolutely.
And that's a great addition to this technology.
That's absolutely. We're going to talk a little bit about that. You're a very good point. Tom, why don't you just walk the viewers through this science slide here, looking at how we're using this light to image the hemoglobin and how it actually works.
So hemoglobin loves infrared light. It absorbs red light and infrared light preferentially as to other molecules that might be in your tissues. So we know that hemoglobin is either oxygen bound to it or unbound. And so when you shine the light or image through the skin, and red light goes deeper, infrared goes deeper in the tissues than say violet light, the hemoglobin will absorb it, and then it'll re-emit light. And because, as you mentioned earlier, there are different wavelengths, you'll get different images, whether there's oxygen on the hemoglobin or it's deoxygenated. And then we can compare those two.
So then the device then takes a computer algorithm with those wavelengths of light, does some analysis, and produces a pretty picture.
So it is a pretty picture indeed.
And we're going to be spending a lot of time talking about the interpretation of those pretty pictures here. So let's look how it's used clinically. Here's a little video clip. You can see that little bit of laser light to get the right focus on the right in the center of the wound. The camera is then used to image the wound. As Tom mentioned, there is as you can see, an RGB image, a regular digital image, and then selectively the look at the oxygenated versus deoxygenated hemoglobin image. You can see those there. What's really cool about this technology is that you can actually touch those photographs and generate a perfusion number. And we'll spend some time talking about that. So that's how it's used. Very simple. It's a bedside technique, can be accomplished in literally minutes. And as Tom mentioned, with that digital image, you can capture your digital photograph at the same time you're capturing your near-infrared spectroscopy image, so you get 2 for 1 here.
Right, and that makes it a whole lot easier. Think about how we were doing it in the past.
Yeah.
In the old days,
Right.
Where we would have to send the patient over and get a transcutaneous oxygen measurement. It takes an hour to do, and now you can do it, right in the room, right in the clinic.
Right, bedside.
Hey, is this guy a good guy for HBO? And
you know, they talk about point of care and wound care all the time. This is really a point of care device. Great. So here's a little image to show you a quick comparison. This is one of my patients, pre and post hyperbaric. And what you'll notice here is that the image on your left was pre-hyperbaric using near-infrared. A lot of greens and a lot of blues, and we'll talk about those values. Versus post-hyperbaric, you can see the intense increase in the reds and oranges. And again, you see those little circles with numbers. Those are big increases in oxygenated hemoglobin. And again, we'll spend some time talking about that. So let's move into image interpretation now that we've got an understanding of what this is. You know, in any area of medicine, regardless of whether you're using near-infrared spectroscopy, whether we're using transcutaneous skin perfusion pressures, there's always some variation in the interpretation of the values that you get. And you can get low oxygen saturation, Tom, decreased oxygen supply. That could be, you know, decreased local perfusion, decreased cardiac output, anemia, hypoxia. There's a number of factors.
There's a whole lot. Yeah, if you're anemia and there's not that much hemoglobin going by, so it does correlate with perfusion. But I think one of the important things, and I think we agree on this, is that it's not a direct measure of perfusion. We're really measuring oxygenation. We have other tests that measures perfusion. And in our clinics, we like to get both.
Yes, absolutely.
Oxygenation and perfusion.
Absolutely. If you have states of increased oxygen extraction, such as seen in certain inflammatory states, I'm going to show you some examples of that. Infection, we've actually looked at near-infrared spectroscopy in infected patients, and there are differences, definitely different. So if you're removing that oxygen from the hemoglobin, obviously that's going to increase or change your values. Tom, then there's issues with high saturations.
Yeah, so you have you recently revascularized. HBO is the one we see a lot of. I mean, when they come out of HBO, you see this intense red. You know there's a lot of oxygen in that tissue. It's a nice confirmation of all the science that we've studied over the years. And then you may have a mismatch between perfusion and oxygenation. Again, that's the reason, as I mentioned earlier, why we like to get both studies. And tissues may not be able to use oxygen, and you may have a high saturation.
We're going to delve into the hyperbaric issue. That's, I think, a very impressive area. We're going to spend a lot of time focusing on it.
I can see the future of us, dust on the TCOM machine and the snapshot being used as a device.
Or eBay TCOMs.
eBay TCOMs. Exactly.
So, Tom, I've listed here clinical applications. I think we're both in agreement with all these. We're going to spend a lot of time looking at hyperbaric, and we both are in agreement. This is certainly a replacement for TCOM. We've used it pre and post debridement.
Yep.
I've used it in shockwave treatment. We're going to go through that. Transdermal oxygen, that's a big area that you're interested in.
Yeah, so we've just completed a major clinical trial in transdermal diffused oxygen. And now we're beginning to look very carefully at what it does over a period of time. And that's still an evolution in process, but I can tell you that you can monitor the ability of topical oxygen to deliver oxygen to the wound.
Excellent. E-stim, I've got a case to show there. I've mentioned infection just a little bit. We've got some interesting early findings in compression. And this actually is, I have to credit my son Jonathan. He said, Dad, this camera not only produces oxygenated, but hemoglobin desaturated
Right.
image, and he found some interesting things there. So that's another area to explore.
And that's another weakness of TCOM. You got a big swollen
Yeah.
leg. You ever try to do a
Right.
big swollen leg with a TCOM, and
Right.
you're trying to compress it before you put
Yeah.
and
Yeah.
this is another advantage.
And then obviously, I think the bottom line here is that you can do spot checks of near-infrared spectroscopy in between pre and post any intervention. But I mean, the holy grail here is using it prospectively to monitor, those wound changes, over a period of time. There's another big area, Tom, you as a surgeon certainly appreciate these much better than I do, but there are areas for surgical application as well.
In revascularization, one of the problems is you don't get an immediate rebound in a lot of the studies. You don't, your ABI, it takes about, we really don't exactly know the number, but it takes 2 to 4 weeks before you see that jump. You really need a tool where we can look immediately after, and the vascular interventional guys can look in the recovery room.
Right.
Did I really get it open?
Yeah.
And then for flaps and grafts, we were talking about hyperbaric, but I mean, qualifying a patient for a flap or a graft, nothing's better than a picture.
That's right. And I got a case to share with you in that area that we actually got hyperbaric approval based on our Kent imaging. So it does flap. All right, we told you we're going to spend a lot of time in the area of hyperbaric, and so let's start the interpretation section of this, looking at hyperbaric images. So here you see pre and post, the standard digital photographs, RGB quality. If you look at those, maybe, Tom, I can see some differences, but
I don't.
boy, I tell
I don't
you
see
what,
any difference at all.
if I convince myself that there's
Maybe
some changes, maybe.
But if you flip them, I wouldn't say anything.
I agree. But the importance of this lecture is what happens when we take and we add near-infrared spectroscopy. Well, there the change is obvious.
It's obvious. Yeah.
So when we look at these images, Tom, we get obviously the color output, we get the standard digital photograph, but again, the important part of this technology is actually being able to touch the image and get a readout of the oxygen saturation at the point that you touched.
Yeah.
A true analog value that you can compare and contrast to. And I think this is important, Tom, looking at this. And what does this mean? If I were picking up this camera for the first time, how would you use these images? I mean, what do they mean to you?
So I think that's important, Jeff. And I think another thing is that I think people are used to technology where it's a one-time. It's an ABI. It's not going to change over the next 3 months.
Right.
But that's not true. This is picking up oxygenation at a moment in time. So a longitudinal use. And you have to keep that in mind. So, and it's nice the way you've marked that there, and then I think this is Jonathan did this work. Yeah.
Not me.
I could tell. It wouldn't be me either. I'm not that good. But he's marked it, and then he goes back and marks the same areas. And what you see is an improvement over time. And this is what we need, and this is the holy grail for hyperbaric. Am I making a difference in hyperbaric? I'm treating this patient. I'm 20 treatments in. Am I doing anything?
That's exactly right.
This is kind of technology I think really holds a lot of potential for the future of follow it longitudinally, and just like you're doing, we kind of copied off of Jonathan. He really did a great job, and we're copying that, looking longitudinally over time to see what happens.
Let me share another case with you, Tom. This is a pre and post hyperbaric patient using near-infrared spectroscopy. This is a patient actually with some frostbite. You can see the tips of the ring finger and middle finger, those dusky changes. And again, pre-hyperbaric, post, here's your near-infrared spectroscopy, correlates very nicely with, and here's post-hyperbaric. Now, I grant you can see some improvement here, but when we compare it to the near-infrared spectroscopy image, I mean, that is impressive. And again, we can then touch those fingertips, which we did, and there is a marked increase.
And not only, you're not only convincing yourself with that, but you might have to convince payers. Like, I'm not treating this frostbite guy, but here, look. And there's nothing that they always say pictures worth 1,000 words, but it is worth it. It's probably worth $1,000 too, because you're going to get reimbursed when you show these pictures.
So Tom, we mentioned that we were going to spend some time on near-infrared spectroscopy and TCOMs. I know that I'm preaching to the choir, you're preaching to the choir, and we talk about this. My TCOM machine is sitting on the shelf, dusty already. We haven't used it in 3 years, quite frankly. The near-infrared has replaced it. And for a number of reasons, I think there's significant limitations with TCOM.
Right.
The time involved, 45 minutes to do an adequate study. And again, it's too cumbersome, too labor intensive.
One of the interesting is TCOM's been around forever. And I wonder today if you took TCOM and you tried to get its approvals, it has such a great intra-rater reliability. So inter-rater reliability. In other words, if I take one tech and one nurse and I have them do the test, they get two different results. Our clinic, I don't know how I think it's the same in yours. We only one person is allowed to do TCOMs. No, only that's it, and that's only person because that's the only way we can get consistency.
Right. Absolutely. So the question that I get asked a lot is, what do these color images mean, and how do you translate that to the standard number that I'm used to getting from TCOM? That 40, that 30 millimeters of mercury, less than 30.
A lot of literature around that.
There's a lot of literature. So oftentimes I'm asked, well, yeah, this is great. We can get it quickly. I love the color images, but how do I jump from this image into a comparison with TCOM? Let's look into that. I know you've done some work. We have as well. You might recognize this this study. We put in a poster, and essentially what we did, Tom, is we actually looked at a patient, and we put TCOM leads, and we did our TCOM evaluation, and then we imaged it with near-infrared spectroscopy. We picked out 2 leads there, and we sampled around. Obviously, you can't sample a near-infrared spectroscopy over the lead. You're not going to have a value there. We sampled around, and we did averages. And we had very nice correlation. You see the TCOM average here is 69, where the near-infrared, and this is lead A, was 64. Not bad.
Yeah.
And lead B, 52 versus 56. That's pretty tight.
It's pretty tight, and that's there is a formula that goes from one to the others, and so those are almost equivalent if you pop those in the formula. I mean, the other issue here is, and I love the way you did this study because the sensor then heats the skin as well, so that changes the oxygen dissociation curve. So having this kind of correlation really means that it's very tight correlation.
Yeah, perfect. So I know, Tom, this is an area of interest to you. You've actually done research and published in this area. Would you walk us through your recent publication?
So what we did in this case is, this is really our pilot. We were looking to get a grant.
Right.
But they won't give you a grant to study something until you've already done something. That's how it works. That's the way all grants work. So we took a small number of patients. It's I think I don't know the exact number, 15 or so, and we compared directly NIRS to TCOM. Now, I will tell you that it's not a perfect study because you learn during these studies.
Sure.
The temperature was, the lead has a certain temperature, and we didn't heat up the wounds before or legs before we took the TCOM. But still, given all of that, we had a very high correlation between TCOM and near-infrared spectroscopy. Very high correlation.
So, Tom, I know this is an area of interest to you, an area of passion, you might say, and you've actually researched this and published on this. Why don't you walk us through the study?
So this is our first publication, and we're working now on the second part. Well, you know how grants work. You don't get the grant until you've actually shown that you've done something.
Sure.
So this is our pilot study, and we looked at comparing directly near-infrared spectroscopy with TCOM.
Okay.
And it was also a learning trial for us as well, because the TCOM lead heats the skin, and one of the things we learned and we put in the subsequent trials is you also have to heat the leg before you take the snapshot image as well. Otherwise, you don't get as good a correlation. But despite all that, even though we had a small number of patients, about 18 patients, we still got a very good correlation between the TCOM values and the near-infrared. And what does that mean? I mean, you know, but it means that we can take all that TCOM data that's been done over the years, and we can say, well, if that demonstrates healing and these two work the same, we can sort of use all of their data when we're making our decisions about patient care.
We're not starting over. We're leveraging all the historical data we have, all of those interpretations of TCOM value. We're just moving it forward.
Right.
That's
just
great.
A simpler way to get to the same number.
So this is from the study.
Yeah, this is from the study, and it's similar to the slides you showed. You can see that the red area there where the two leads are, and you see 71 for the TCOM and 77. And I will tell you, when you correlate those mathematically, that's almost an exact number.
Okay.
It correlates almost exactly. But this is a well-perfused lady she has a venous leg ulcer, she's under compression, so she's well controlled. I mean, we're going to talk about compression a bit later, but she's been compressed, so it turned out quite nicely.
Good.
This is a problem with TCOM. We'll talk a little bit more about some of the limitations of TCOM that we've all experienced for years and years. And that is the area I really wanted to study was the erythematous area there, where more of the wounds are.
Sure.
But you can't put a TCOM lead there.
Right.
It's not going to work. The same thing is true when I know if you ever try to put it on that lipodermatosclerosis and that terrible venous skin, you put it on there. I just did one yesterday in the trial. I put it on there. I got a 21 on a, just clearly it wasn't 21. The ulcer was healing. It was just where we put the lead. So we ended up putting the lead way up on the leg, and what is that? What does it tell you? And this is just another example. You can see where the lead is. It actually looks pretty good, but where the area of interest is, it's blue and it's hypoperfused. And this is again one of the limitations that goes with transcutaneous oxygen.
You know, the other thing I'm going to point out here, Tom, it's obvious to me, is I get one spot check of that leg with this TCOM lead. Versus look at that photo. I mean, that gives you a lot of data. We're not only looking at the area of interest, but those other wounds we're looking at. You can see that more proximal lesion, very dense area of redness. That suggests more of an inflammatory process or more of down the healing process. So we're getting data that is almost global from the picture of the wound versus just a spot check.
And let me ask you a question. How many times have you done serial TCOMs?
Right, exactly.
Never. So, but that's the beauty of this as well. So I look at this, so maybe we do something that's anti-inflammatory. Maybe put a gel or something on that's anti-inflammatory. And now we want to take another picture a week later. Right. We have that ability. Certainly not going to take a TCOM every week.
Yeah, exactly. So tell us about this. This looks interesting.
So this is from one of our clinical trials, and it was a really great clinical trial. It actually failed, but it was still a great trial. You know, sometimes it's other things you learn from trials that are just as important. So this is a plasmid gene transfer, and plasmid's a bacterial DNA. Right. It's a big circle, and the really super smart people that got this idea spliced in human fibroblast growth factor into that, so it's a human angiogenesis, and then we injected it into patients. Okay. Great trial. It didn't turn out in phase 3 to work, but we learned a lot. One of the things I learned a lot about was TCOM. So the first, we did this trial in an old part of our hospital. The hospital had given us for a research section. Of course, they don't give you the nice, new, shiny part of the hospital for the research. They give us this old part built in the 1800s. And so patients come in, and the first day we do a TCOM, and it's 8. Oh, enrollment trial. Next week, still in screening, it's 40. Next week, it's 10. And I called the company and said, you gave me a lousy TCOM. So they come, they look at the TCOM's fine, and say, well, what's wrong? And then the company came and they looked at where we were, and they said, you know, the temperature really varies a lot between and then it turns out that the temperature of the room's got to be between 68 and 72. And if you're in an old part of the hospital, you better do your TCOM somewhere else because you have to. So I said, okay, now tell me for this trial, because we're doing TCOMs every week in this trial. What else do I need to know? Well, the patient can't have caffeine. The patient, they got to lie flat for 45 minutes per hour. They can't talk during that time, which for me would be impossible. I would never be able to do that. And they have to lie supine. And so there's a lot of limitations. We mentioned inter-rater reliability. So this is, people say, why are we looking at this? Why are we spending so much time and research and money in looking at an alternative? Well, there's a lot of reasons for this alternative. And I think anybody that's used TCOM on a regular basis, as we have for years, knows, boy, I really would like a better alternative.
Sure. I'm just going to comment. You must have been the patient here. I see the 2 cups of coffee. You can't get your day started without at least 2 cups of coffee.
Exactly.
Yeah. So, but it does bring up an interesting point. Caffeine, room temperature, patient temperature. Have you noticed that there is that much variation in near-infrared imaging as we saw with TCOMs, with all those different variables?
There really aren't. I mean, I like to get the temperature. In the trials, we had to get the temperature right because of the oxygen dissociation curve. But in the clinical setting, no, you don't have to. We don't worry about temperature. I don't like patients to take caffeine before I image them, but I don't really care. It has a broader, it captures a broader range of values.
I agree 100%. And again, that makes this device, again, superior to the TCOM. So very interesting study. Okay, the next area we're going to focus on, Tom, is wound bed debridement. I know you've got some interesting observations here. We certainly do. Here you can see the ultrasonic debridement device Arabella in use. You use that a lot clinically. But again, this is the way it used to be, Tom.
Yep.
You get pre and post, and you look at it and you go, hey, that looks pretty good.
Yeah, it looks great, actually.
But not every debridement is like that. And the question is, you know, are we improving the wound itself over time? So when we combined near-infrared spectroscopy, we're actually getting some additional proof. If you look at the wound-based pre and post, you're seeing that, removing that, stimulating that. We talk about debridement recreating the acute wound. I think this is great evidence to show that we're doing exactly that.
Exactly.
So again, I'm going to remind the audience that, again, using the camera, you can touch the image and actually get your numerical values of those points of interest. And I know it's difficult to see from this slide here, but there's a clear jump and increase in oxygenation between those two images.
And you can just see that, the gestalt of that. You can just see that it definitely looks better.
Yeah. And so I think this is a great place, again, to step back and say, you know, interpretation. So, you know, I don't really care at this point. I mean, I do care, but I don't really care. I don't really care what the numbers mean here. It's the change in images here where clearly you can see that we've gone from a wound that was, you know, maybe red in the central and with a robust yellow, again, yellow indicating lesser hemoglobin oxygenation, to a wound that is essentially all red, again, suggesting increased oxygenation of the hemoglobin. And that comparison is what's important to me.
Yeah.
You know, I don't, you know, the number, whether it's 60 or, you know, 40 or 30, that doesn't tell me as much right now. And maybe we'll get to a point someday that we'll have that translation.
Oh, we will. And we'll have that in the future. I mean, it's part of our ongoing efforts is to kind of hone in on what those numbers mean. And it may not, as you said, it may not really be that saturation number. Right now, I do like you do. I do longitudinal, and I can look at it, and I don't need a number to tell me that's better.
Right, exactly. And so I think this is a good example of that. Tom, I think this is a case that you want to talk about?
Yeah, so this was a gentleman with an obvious large venous leg ulcer. I will tell you the story. He's been hiding this from his wife for 2 years.
Wow.
And doesn't want to see the doctor for it. And one day wears socks a little too short. And she drags him into the clinic, and we looked at it and said, well, you see that dark area on the bottom there? That was an area of concern. I actually thought incorrectly that it was increased bacterial burden. Okay. And so we took a fluorescence image. You can see that over there. It's not positive where the dark area is. It's actually positive in the middle. Yeah. There's a little bit of bacteria there that will need to debride aggressively there. So what's the dark image? So we took a near infrared image, and now you see it's just not perfused. It's dark. It's black. So this is a poorly perfused area, and in the middle of this wound bed. So clearly that's an area of non-viable tissue, although you don't really know what it is until you have some information. We know it's not infection. It's just an area that's debrided. I need to debride.
So Tom, you did a debridement.
Yeah, you can see we've debrided off that darker area there, and pretty much wherever we saw it. And now near infrared shows that it's well perfused. Treat the area, debride the area where there was increased fluorescence image, and then debride the area where you have this. So this is using optical physics to improve the care of our patients.
Yeah. You know, I've also seen the term optical biopsy.
Yeah.
I think that's very appropriate for these debridement photos. You know,
yeah, I think that's
getting those areas that may be necrotic, maybe, from bioburden, other factors can influence, but interesting to actually get a biopsy of the wound with this. Another area that we've looked at is shockwave therapy. Tom, I know you've looked at this. There are a number of devices out there. I think that some of them have been proven very well in a focused area of wound care. Others have a little bit more of a broad scope. We've looked at this fairly intensely.
Sure.
And here's an image, again, that I think really speaks to the value of near-infrared spectroscopy. This is a patient with Raynaud's, and you see the pre-shockwave and post-shockwave. Now, we know that shockwave therapy does stimulate tissue perfusion.
Yeah, clearly.
And we've been using these terms, perfusion, oxygenation, sort of interchangeably here, and I'm not sure that that's necessarily accurate. But
guilty, yes.
Guilty, yeah. So it's really hard. But here on the left, you see pre-shockwave, on the right, post-shockwave, and clearly these images do suggest a difference. We then imaged with near-infrared spectroscopy, and again, you can see the increased oxygenation, again, suggesting what most people would surmise is that we've stimulated the perfusion of that tissue.
Right.
Perfusion carrying oxygen on the hemoglobin, and we're seeing the difference here. What's really cool about this, Tom, is that this patient had profound pain because of her tissue ischemia due to her Raynaud's, and she came in the next day begging for another treatment because of the improvement in pain. And we imaged her the next day, and again, persistent improvement in oxygenation. Kind of a cool finding. And again, looking at those images, Tom.
Longitudinal.
Again, longitudinal, comparing the center top to center bottom, there's clearly a difference. And again, is it important, Tom, to, we have the ability to touch a screen and get, the absolute number values, but is that important to you from an interpretation standpoint? How would you look at this image and interpret it for us?
So I'll tell you one thing, I wouldn't even check the numbers on this one. I wouldn't even press the buttons. I mean, obviously, your technicians, Jonathan did these pictures, but your technician's going to press them because we tell them to do. But I personally, if I was taking this myself, I wouldn't even. I'd say, fine, we're done.
We're done.
Yeah, we're done.
And we improved.
We improved, no doubt about it.
So another area that we've both been playing with, there's I think increased interest clearly in topical oxygen, transdermal oxygen. You can use a variety of terms to describe it. But we've looked at transdermal oxygenation, and the question is, does this therapy work? Right. Do we actually improve oxygenation of tissues?
Exactly.
I can tell you, at least in our opinion, without a doubt, it works.
Yeah.
And this is an example of, I'd love you to comment on it. So this is an oxygen reservoir device, Oxyband, and here you see pre-topical and post-topical. And this is several days, Tom. So what we're seeing over time is, again, that image on the left. I see areas of blue and green, clearly not well oxygenated. If you look at the center of the wound, there's almost a punched out area that is less intense than the peripheral. This is important because I'm seeing that intense oxygenation around. I think this screams of inflammation, an inflammatory response to the wound. And that makes sense. Increased inflammation, increased tissue perfusion, increased tissue oxygenation. But after we treat with Oxyband for a couple of days and we oxygenate, look at that tissue has significantly improved in the amount of red and orange with a decrease in the yellow-green images here.
Yeah, as we said previously, I don't think there's any doubt that there's the evidence for transdermal oxygen is growing. There's 3 clinical trials that we're in the middle of doing. You and I are in the middle of doing a meta-analysis on it. And as old hyperbaric guys, some people are calling us traitors. But,
heresy.
Heresy, exactly. But that's not. There's room. This is a huge industry. There's room for both devices, both hyperbaric and topical oxygen. And I agree with this 100%. I think.
Well, not everyone qualifies for hyperbaric.
Right, exactly.
Not everyone can access. There are wounds that are hypoxic that just don't meet criteria. You can't put them in the chamber, or you should be putting them in the chamber.
Right.
There's people that do.
There are.
But if you can't, we need to oxygenate these wounds. And so I think topical or transdermal is a complement to hyperbaric. It's an adjunct to it. I think it expands our ability to treat patients with hypoxic wounds, so it just makes sense. And I think the fact that, hyperbaricists, pure hyperbaricists, for centuries have poo-pooed and, and tried to kill that because it was a competitor, right?
Yep. Well, the other thing is, too, is if you look at all the trials that have been done, 3 trials, they're all done in Wagner 1 and Wagner 2, hyperbaric's Wagner 3, and you're always trying to explain to people, look, it's a different indication.
Yeah.
I would never put a Wagner 2 in hyperbaric, although some do. But I would use topical oxygen on the Wagner 2 without hesitation.
Without hesitation, yeah. Another area we've looked at, Tom, is eStim. We've had some really interesting, this is a new eStim device, True Relief. We've had some really good clinical success. And this is pre and post eStim. And difference in the wounds? Not
Hard
much,
to see, yeah.
This patient did heal over time. I don't have that image in. If someone wants to see the whole case, I can send that to them. But again, pre and post, and this is to just illustrate what we see with near-infrared. So again, looking at these images, Tom, that's an improvement.
Yeah, no doubt.
And again, do you need numbers here?
No, I think at this stage of interpretation, I would encourage people not to get hung up on the numbers. And you're getting those calls. I'm getting those calls. What's this number mean? Forget the number. Look at the image. You look at the colors. Look at the improvement longitudinally.
Right.
And right now, I think that's where we are.
I want to talk a little bit about the images here. I think it's important to talk about where we're looking and where it's important. So, what do you think about that earlobe, Tom? I mean, there's yellow and green that underlines. Is that ear ischemic based on this Kent image?
No, I think that the ear is probably okay based on this image. There's some tissue around it, but also you remember you're outside the field,
Right.
so the image takes a box,
Yep.
and you really want to concentrate on where you put the laser beams come together, because that's really where you're getting the oxygenated and deoxygenated oxygen images back. You're going to get, like, oftentimes you'll see legs, you'll see really blue. Oh no, is that ischemic over there? No, it's just outside the field.
Yeah, and the curvature of the tissue makes a difference. I think this curvature here and shadowing certainly. That eschar that you see in that lower corner, obviously that correlates there. And so you need to understand that the contour of the wound and the tissue is going to be variable. It's going to give you some differences in oxygenation. And, this camera is a device, and it's not perfect, okay?
Right.
So you're not going to get perfect interpretation of that light hitting all the tissues based on the different characteristics. I would encourage the audience, and what I have done is I focus on the wound.
Yeah, you have
And,
to.
you kind of get a gestalt of what's happening around the wound, but more importantly, let's look right at the wound.
And that's why I think when you're starting off too, it's not a bad idea for the physician, clinician, provider to take the image of yourself when you're starting out. So you get the sense when you take that laser and you put it together. This is where I'm concentrating.
Right.
This is the box I'm in, and I'm not looking at it. If you start off right away with the technicians doing it, you're going to lose some of your image interpretation abilities. So and then once you got it down, which doesn't take very long, then you can pass it off.
Well, for you maybe a little longer than
longer
others.
for me, of course.
But that's right. This is an interesting case I wanted to share with you. I think it's fascinating. So the image on the left is a patient that came in, venous leg ulcer, grossly infected, and you can see the eschar that's there. The picture doesn't do it justice. The digital image doesn't do it justice, but a lot of inflammation, a lot of peri-wound edema, and we snapped an image of her, and you can see that a lot of dark tissue in the center of the wound. But look at the peri-wound here. I think this is kind of interesting. It is really, I think, if you will, non-oxygenated from a global standpoint.
Right.
You wouldn't expect this in a venous leg ulcer.
No, you wouldn't. Yeah.
But we treated her with antibiotics, continued her compression, so she's using compression. But look at the post-antibiotic after we resolved the cellulitis. It's kind of impressive.
Yeah, so you resolve the cellulitis, you resolve the inflammation, and decrease the edema.
That's right.
And all those things are going to give you better perfusion. I think it clearly demonstrates that.
But again, we're looking at the wounds here, and
Right.
again, I'm targeting the wounds. I don't need necessarily numbers to tell me that this is improved. Visually, there's a nice contrast in comparison.
Yeah, last few slides we haven't shown any numbers at all.
Yeah.
And look, we all want numbers, right? We all want help, and we're used to. And that was a thing from us T-commerce to as we moved forward, we wanted that number. But starting out, even if we do find the numbers that correlate, still, I would say turn the numbers off first. Look at the images.
Absolutely.
Learn to interpret them first, and then when we get the numbers down a little more, then you can add those on.
Yeah, I've used the numbers more from a research standpoint than I am from a clinical standpoint. Speaking of clinical issues, surveillance, I think this is really important. We use our imaging not only from a single intervention, so pre and post debridement, pre and post E-stim, pre and post shockwave, but I look at this over time and see the progression of tissues over time to actually see, are these debridements making sense over time? Do I need to continue to debride? Is the compression working? Is, our shockwave, are we getting an added benefit here? So I think that's really important.
And we mentioned earlier, we need a device in wound care. We're seeing our patient once a week. They're in hyperbaric every day. We need something that's longitudinal, that we can do longitudinal studies with, without a doubt.
So prospective monitoring is clearly important. Here's pre-intervention, post-intervention, and you see the changes just, a week out. We're throwing obviously a lot of modalities at this patient for salvage.
Mm.
But again, looking at this, Tom, there is no doubt in my mind that those areas of compromise are reflected by the dense blue, dark, yellow, green, has improved after a week of interventions.
Yeah, there's no doubt. I mean, you look at that and you say, we're going the right direction, and that's what you want. What you really want is a yes/no answer here, and that's no one's going to say. I mean, no one I know is going to say no. That's not better. And that's what you're looking at. Yes, what I'm doing is working.
Yeah.
Okay, keep going.
Yeah. The other thing that I'd like to close with is, I think there's some value, and I'd love to get your opinion on this, is the look at prognostic imaging is what I call it. So you get that initial image, and you look at it and you go, is this healable or not? There's data in the TCOM literature to get an absolute value. You go, hey, listen, there's no response to hyperbaric, patient doesn't qualify.
Right.
Or, based on this number, this patient's going to end up with a BK, right? No limb salvage. I believe that near-infrared spectroscopy provides as much information, if not more, on prognostic imaging. And we're looking actually at a hyperbaric study right now where we're getting some initial hyperbaric images, the values and the data from that, and looking to see whether they get a favorable response to hyperbaric. And we're finding that there's correlation there. So more to come. I'm hoping to get that paper in the literature. But what is your thought on that?
Well, we're doing the same thing. We got a grant from of all places, the government of Canada. Thank you, Canadians. Appreciate that very much. To study just that, and particularly to look at hyperbaric, qualifying patients for hyperbaric, and to continue our work on TCOMs and that comparison, and to look and see in ways we can use those numbers. But again, I want to stress again, I don't want to, again, if you're using this device and you're new to it, use your eyes,
right.
rather than the math.
Right.
We're humans. We're much better at looking at images rather than looking at numbers.
Right, absolutely. I couldn't agree more. So let's shift gears a little bit. We'll move into more of your prior world, surgical, and here's an interventional case.
Sure.
We use it a lot for pre and post intervention. Longitudinal is also important in intervention, but you'd referenced earlier, this patient goes to the lab, gets a PTA blown open. Are we making a difference? Well, looking at that foot with regular digital images, you can't tell. But I think with near-infrared, there's no doubt that we've improved that tissue oxygenation.
Yeah.
It is.
And this is really important. I think, and we at our conference we had earlier this year, our leaders conference, there was a lot of interest in this from the vascular groups in the audience, simply because you're looking for a way to tell immediately post-revascularization, am I making a difference?
Yeah, no, absolutely. So it's a great example. Another area is flaps and grafts. This is a case that we've looked at. This is a young man that came to us and said, listen, my surgeon's really concerned about this incision. He sees it's dusky all around. I've been doing some research and I found hyperbaric. A lot of patients do that. They do their own research now. But he came to me basically begging me to do hyperbaric. So I asked the insurance company, can we guess what the answer was?
Oh, that's a definite no.
No.
Yeah.
And so what I did, Tom, is I supplied these images. This is, again, pre and post. I gave the patient a trial treatment. There you see pre, and here you see post. And I think that there's no doubt, in my mind, that there's a vast improvement. We provided these to the insurance company, and guess what?
They paid?
They paid.
Wow. I think that's a great example. I think, as this technology progresses, we learn more and more about it. But one thing, there's no doubt that if you're trying to prove to an insurance company that the patient has a ischemic flap, you can send all the documentation in the world you want. You got to send them a picture.
Yeah, there's nothing better than this.
I really like the idea of doing a post HBO image. That was really smart.
Yeah, no, it worked well. So let's just maybe summarize here, Tom.
Sure.
I think near-infrared brings a lot of advantages to us clinically. Obviously this is quick, minutes.
Point of care, exactly.
Versus what was your average time for TCOM?
That's 45 to 60 minutes.
Yeah, that's a lot of time.
That's bringing the patient in, get in there. Most people say, oh, it takes 30 minutes. Well, no. The patient has to sit there for 10 minutes too. Yeah. If you got to count that time.
Yeah, sure, absolutely. And the beauty of near-infrared is not only decreased time, but you can get serial images in a day very easily. There's really no disposable cost with the camera, is there?
Definitely less.
Unless you're dropping it every time.
Yeah, well, it's less expensive, not just less expensive from a disposable cost, that's definitely true. But it's also less expensive. Think about your FTE cost.
Right.
Think about the time it takes
That's
an employee to
Yeah.
do that procedure.
that's a great point. So certainly less costly. It's non-invasive, less burdensome. Patients tolerate it very well. Not that they don't tolerate TCONs, but sitting there, like you said, for 45 minutes is tough sometimes. What I really like best of this, Tom, is that it's insight to its bedside. It's right there. You can look at the wound. You get the wound. You get the peri wound. You get it all at once, and you can look at it again. Pre and post treatment. You can look at it longitudinally. You have that database that really talks about the wound and the changes of the wound over time. So I think there's a ton of advantages here.
I agree. And again, I love the longitudinal aspect of it. And that's just, for us, TCOM's a snapshot. So is NIRS a snapshot of that given moment in time. But it's a lot more information to see it weekly. Or hyperbaric, we do it once a week. I think you do it once a week too as well.
So Tom, I'm going to sum this whole presentation up with a little scenario. So I've never used near-infrared spectroscopy. I just put it in my clinic. I'm shooting some really pretty pictures, but I don't know what they mean. So Kent tells me to get on the phone with Dr. Serena. So Tom, I've got these pretty pictures. How am I supposed to interpret them?
Yeah, so I think, again, don't get caught up in the numbers. Look at the image. The colors are intuitive.
Yes.
They're not, thank goodness, and sometimes these images aren't like ultrasound.
Yeah.
Nothing intuitive about that. You have to learn it. But these are intuitive, and the minute you see them, you sort of realize, that red is perfusion, blue is bad. That's just natural. Look at the image, and then from there you can generally move. And if you really have questions, you can send in early on. You can ask your friends.
Yeah.
And anyone's willing to ask me. I'm sure Jeff is feels the same way.
Yeah.
We're happy to look at them early on. It won't take us very many times.
Right.
Right. And we have that. We have doctors that send us pictures all the time. Say, what do you think? And then sometimes the answer is take a picture next week.
Yeah.
Because that's really what you want to know.
And again, I think we're both more than willing to be available to review your cases, look at your photos, and talk about them. So. Well, listen, Tom, that brings us to the end of this part of the presentation. So I would like to thank you
for again My pleasure.
Spending some time here today. I'd like to thank the audience for listening, obviously, listening to both of us. That's
tough.
They really need to be appreciative of that. But we're going to go ahead and go to the live Q&A, and we're going to provide you an opportunity to challenge us on some of the things.
All right, there we go. Fantastic.
Good. Well, hello, everybody out there. We can't see you. We know you're there, and we apologize for that little glitch in transition. Technology is great sometimes. But anyhow, Tom, I compliment you on the presentation. A lot of good stuff in that presentation, and we've gotten a number of really, really good questions that I think we can run through here. If you're okay, I'll go ahead and read them, and then we can talk about them.
Let's do it.
So we got a really nice question from our friend Cuau Sanchez down in Merida, Mexico. Hopefully Cuau is on, and he wants to know how quickly you can see the changes in the imaging following hyperbaric oxygen therapy. And I think we briefly discussed that, but maybe you could refresh the commentary.
Yeah, so I think you've said this as well, Jeff. We see them pretty quickly. I mean, for example, with hyperbaric, you do an image pre and post, you see a dramatic difference. Obviously, there's a huge difference in oxygen saturation between those two moments in time, but you do see a very large difference in that. And yeah, I think this is a test that detects changes in oxygenation rather rapidly. There's no lag time in getting to our answer. And I know Jonathan and the group that you've done on all of your HBO cases, I think that's been pretty clear.
Yeah, and the only other thing I'll add to that, Tommy, you're absolutely right. The only other thing I'll add to that is that I think there's two things that you're seeing here. Certainly, you see the immediate hyperoxygenation, looking at the saturation when the patient immediately comes out of the chamber. And then you see a drop in those images, as you would expect to see in those post-hyperbaric curves that we typically talk about, with oxygen saturations dropping off over a couple of hours. But in the long term, what we do is we see an improvement in tissue oxygenation over time, similar to what you see in TCOM. So over time, those values will increase on their own, certainly will respond exceptionally well to a hyperbaric treatment, but they also will respond over time, and there will be an enhancement, if you will, over time. I think it's an important take-home note. Greg Bond, hello Greg, hopefully you're out there. Greg wants to talk about before and after images. And Greg, I think hopefully we provided, I know this question came in, before the seminar, so hopefully you've sort of gotten a perspective from Tom and I tonight and how we use these things pre and post, and not just in hyperbaric, but in a number of clinical settings, looking at pre and post responses to a variety of modalities. I think anything that enhances oxygenation and perfusion of the tissues will be reflected by the near-infrared spectroscopy images. And I think, a real splash. In fact, we're actually working on a paper right now with a group out of the Midwest, looking at their results with revascularization. I think that's going to be a really a hot button item for not only wound care practitioners, but vascular specialists as well. Tom, what do you think?
No, I agree. I think, we've been on the search for something that gives you real-time information, and that's what we need. It's very important in the wound clinic, in the cath lab, in the post-op recovery room, in order that you have real-time information that you can make decisions on. If something has a lag time, you can't make a decision. We need things we can use to make decisions.
Yep. Patty Pendleton asks, is there an ability to use this at home, and what is the ease of using the device? Pat, it's a great question. I think it certainly has a role in skilled nursing facilities, LTACs, long-term care settings, regardless of whether it's home or in a facility. And these devices are portable, as we mentioned. They can easily be taken into the facility, and the imaging can be accomplished. So you can use it anywhere. I think as we move forward on these platforms, you're going to find the size of the device decreasing. Eventually I see this being accomplished with just a cell phone, or maybe an adapted type of cell phone. So yes, quite clearly, these can be used in a variety of settings. There's also a question here about the safety and the ease of use, and just the logistics of the use of the devices. Tom, you want to weigh in on that?
I mean, it's easy. Compare this to CCOM. You put the patient supine, you wait 10 minutes. It takes a 45-minute to an hour procedure, and that's what we're used to. However, the convenience of this device really is going to obviate the need for TCOMs in the future, in my opinion. You put the patient in there. Now, we do like to warm the leg up a little bit before we shoot the image, but that's something that can be done even before we walk in the room. It's a camera like device. You calibrate, you shoot, you interpret. It doesn't take very much time.
Right. Miss Kimberly Eldridge is out there, hopefully joining us tonight. And Kim sent a question. Thanks for joining us, Kim. Can these images be uploaded to EMRs? And the answer is certain EMRs are currently able to take these images. I think over time that the number of EMRs will certainly increase. I think this will be a universal pathway where you can take the images and load them immediately to the EMR. So that's coming in the future, and it currently exists in some of the EMRs out there already. There was a question on reimbursement, and This was from Anthony. Anthony, I would recommend that you contact Kent. They have an expert in-house. Her name is Moira, and Moira would be happy to spend hours with you talking about reimbursement. Literally, she's willing to spend hours with you. That's all she likes to talk about. But if you really want the nitty-gritty on the reimbursement, I think let's send you to the expert for that answer.
Yeah, I agree.
There's a question from Chris Barrett. Actually, I'm going to save that one for a second. We've got a couple more questions. Dr. Freiberg is out there, and Bobby sent in a question. Would you expect similar results and changes that we see with hyperbaric with topical oxygen therapy? And I will tell you, Bob, is absolutely. We work with a number of different technologies, and you will see an augmentation of tissue with the topical oxygen applications. And we're not going to go ahead and name them because there's a variety of folks out there, but certainly we will see a change. And you know, I'm working with a technology that can actually, it has a several day wear time, and when you take that image after you remove that dressing, there's a pretty significant enhancement of the oxygenation of the tissues. It's fairly impressive. Tom, anything else?
No, I agree. You know, we're looking forward to doing, you know, obviously we're gathering more information on topical oxygen, and we'll have more to report probably early 2022.
Great. Chris, you sent in a couple questions, and I appreciate that. And Chris, I'm going to make you this promise. In fact, I'm going to invite all of the audience here that we're going to talk more about this topic at Wound Week 2022, and we would invite all of you to join us the last weekend in February in Philadelphia. Tom and I and Chris Barrett will all be there. Extended Greg Bond will be there, and hopefully Bobby Freiberg will join us. A lot of people pose questions here, but it's going to be a great clinical meeting, and we're going to talk about this topic and others in great detail. But Chris, you sent in a very interesting question. I just wanted to kick that out there and then suggest that you and I can connect, because this discussion takes much more time than a few minutes. But Chris commented that there is, you know, an oxygenated and deoxygenated hemoglobin view, and how do you use the deoxygenated, and do you use the deoxygenated hemoglobin view? And long story short, Chris, yes, we do. We're starting to find that the deoxygenated values are very helpful in certain categories of patients and in response to other therapies that you wouldn't necessarily expect. I don't use the deoxygenated views much when I'm really placing the patient in the chamber and that sort of thing, but I will tell you that states of congestion and inflammation, such as those patients with the severe venous insufficiency and even in lymphedema, we've discovered some utilization of the deoxygenated views with pretty impressive results. And I have to actually give my son some credit for this, Tom. Jonathan, you know him. He's hopefully will be in medical school soon. Actually has done some pretty nice initial work looking at the deoxygenated views. And I think, again, as we have both suggested, you know, there's more to come on this topic.
Exactly.
Any thoughts, Tom?
Well, I know the deoxygenated view is more things affect the deoxygenated than the oxygenated view. So as you become more comfortable with the device, you'll I think we learned, oh, is there edema? Is that sort of affecting the number? Let me look at the deoxygenated view and see what the impact is, and we'll also be providing more information in the future about how to use the deoxygenated view to increase the accuracy of what you're seeing visually.
And as I suggested, you know, Kent is a sponsoring entity for Wound Week, and again, you're going to be able to play with the camera, trial it on yourself. There's a lot of things that you can do without wounds to see and demonstrate how the camera works and the changes in tissue, and they'd be happy to walk you through that. I'm sure Moira will be there, so if you've got questions on reimbursement, she can walk through. There's going to be a number of posters on this technology. So I think this technology is exciting. It's not going away. In fact, I think it's going to really expand in wound care and other specialties, and certainly be a huge enhancement to the way we clinically practice. So Tom, I see we're up at the top of the hour. I know we've been
Yeah.
slated for an hour, so we've run through the list of questions, and I thank all of you for contributing to this session by submitting questions. Hopefully we provided some insight and some answers to those questions. I'd like to thank you, Tom, for spending time collaborating. It's always fun to work with you, and I think this this webinar was kind of fun, playing back and forth. You know, when I was doing it, I actually got the feeling that we were in front of a football stadium doing the side-by-side announcements, the play-by-play.
Yeah.
But anyhow,
it was a lot of fun, and thank you very much. And thanks. It's always fun to visit the studio up in Milwaukee. It's great. And thank Kent for sponsoring it. And if people have other questions, if there's probably some we didn't get to, feel free to give us a holler.
Yeah, absolutely. You can reach both Tom and I personally directly, or you can reach out to Kent, and I'm sure that they'll put us in touch with you. And again, I would like to just echo what you said, Tom, and thank Kent for sponsoring this webinar. They're really a progressive company. They've got great dreams and vista for the future. I think they're going to be a big part of it. And they really have their eye on the mark of the future of wound care. I really believe that, and this technology certainly speaks to that. So it's going to be fun to see Kent grow and help us to perform clinically.
Sounds great. Looking forward to it.
All right. Good night, everybody. Thank you so much.
Good night, all.